Hello class, this is Firefighter Safety and Survival, Chapter 13, Providing Emotional Support. This chapter discusses the effects of physical and psychological stresses from a critical incident on the health of emergency responders, examines the differences between critical incident stress and post-traumatic stress disorders, compares the components of an Alcoholics Anonymous meeting and a critical incident stress debriefing, and lists some of the ways individual therapy is available to emergency responders. The objectives we're going to cover in this class are as follows. We will compare the effects of physical and psychological stresses of a critical incident on the health and well-being of responders. We will explain the myths of relying on alcohol or drugs to cure depression, and list the differences between critical incident stress and post-traumatic stress disorder. We will also compare the components of an Alcoholics Anonymous AA meeting and a critical incident debriefing. We will define psychotherapy and explain how it is normally applied to fire and emergency services, and explain the differences between demobilizing, defusing, and debriefing in critical incident stress management, or CISM. And finally, we will list some of the ways individual therapy is offered to emergency responders, explain the features of an effective chaplaincy program, and describe how technology influences confidentiality for psychological support. The fire and life safety initiatives have appropriately devoted both an initiative to address responders' physical health, which is Initiative 6, and a separate initiative to their emotional health, Initiative 13. Although each is equally important, it is interesting to note the ties between the physical and psychological sides of human beings. For example, two 54-year-old men have similar symptoms, but one is having a heart attack and the other is diagnosed with an anxiety attack. Many times it is difficult to ascertain the source of our problems. Our response to stress is fed both from the physical and emotional strains of the incident. Both the physical and emotional stresses combine to exacerbate the effects of each other, taking a toll on your body. This stress has both short-term and long-term effects. Some effects of stress are exhaustion and lethargy, slowness to respond or recognize that you need rest or feel like you need excessive rest, and details of the incident are hard to forget. They play like a time loop over and over and over in your mind. Now let's talk about coping with stress. We are all victims of both physical and psychological stresses, and we can set ourselves up for failure if we're not prepared. It is safe to say that all emergency responders feel some sort of emotional pain as a result of the duties they perform. Although we are trained to accept the death and destruction we witness, we must also realize that we are only human, and it is impossible for us to not be affected at some time and at some level. Boot camp, or basic training for the U.S. Marine Corps, is designed to initiate soldiers into the duties and culture of the organization, but also tends to, quote-unquote, weed out the recruits who cannot handle the physical and emotional stress of combat. Although fire and emergency services do not have the same initial training regimen, you may recall that some of your classmates failed to complete it or graduated and then decided the job was not for them. Burnout, as it is called, can occur and many times is the direct result of the psychological stresses of responding to emergencies. Incidents that have the ability to inflict emotional damage to responders are referred to as potentially traumatic events, or PTEs. Two specific examples of unhealthy coping mechanisms are alcohol and drug abuse. Let's talk about alcohol abuse. At one time, many believed that alcohol was the answer for both physical and emotional pain. Although better treatment and medications became available for physical pain, alcohol was still presumed to be beneficial for psychological pain. It was not uncommon for rescue workers to try to ward off despair with alcohol. Unfortunately, alcohol itself is classified as a depressant, and it is a depressant. It depresses the central nervous system. But alcohol is considered as a depressant and therefore proves ineffective for the fight against depression. We have come to understand that there is a difference between alcohol use and alcohol abuse. The line between the two isn't clear, and it literally will vary from person to person, but there is that line. According to Alcoholics Anonymous, or AA, some of the symptoms of alcohol abuse or alcoholism can include a physical and emotional desire to drink beyond control, a need to continue drinking after the first drink, and drinking when there is every reason to stay sober. Now let's talk about drug abuse. In the past 40 years, illegal drugs and controlled medications have become much more prominent as an influence on emergency responders because drugs are quicker or more effective at alleviating pain. Drug use is less obvious to family and friends. Emergency responders have access to controlled substances. Now we'll talk about failure to cope with stress. When alcohol and drugs do not help an emergency responder cope with the stress, it's likely to bring on severe depression. When suicides occur on duty, there is no secret, and statistics are clearly recorded. But when a suicide occurs off duty, the statistics are not tracked. At the very least, suicides are kept as quiet as possible, but some are beginning to take notice. According to USA Today, emergency workers committing suicide is emerging as a quote-unquote disturbing trend. High visibility rescues involving the trapped miners in Pennsylvania in 2002, the events of September 11th, the Oklahoma City bombing in 1995, and even the Jessica McClure rescue in 1987 all resulted in later suicides by emergency personnel. Many times other events such as family problems or the death of a loved one contributed to the suicide, and it's unclear how many influence the rescue had. Regardless, many firefighters and emergency medical technicians or EMTs can name fellow responders who have committed suicide. That's why it's important to look at ways to support Initiative 13 and expose the causes, signs, and symptoms of stress. Although not officially labeled as such until the last 30 years, post-traumatic stress disorder, or PTSD, has probably been around as long as humans were chased by wild animals and villages were overtaken by volcanoes. There are varying severities of critical incident stress based on how an individual reacts and copes with events. Acute stress disorder is a term used to describe a possible precursor to PTSD with symptoms that generally last less than a week. PTSD is generally considered the most severe form of acute stress, many times incapacitating the person and preventing him or her from living a normal life. Signs of PTSD could include avoidance, seclusion, flashbacks, significant changes in eating or sleeping, sudden and unexplained rage. Sudden rage can be triggered by a memory, a sound, the location of an incident. For example, roadside memorials. They always disturb me, and I'm not even stressed about the incident itself that caused it to be there. So you can imagine if someone lost someone on a roadside and they go by one every day, if they're suffering from PTSD, that could trigger it off. The most common treatment for this type of stress can be broadly classified as psychotherapy, which encompasses varied forms of treatment and uses counseling as an avenue for healing. The needs of the victim dictate the appropriate level of care. Traditional psychotherapy would be at the upper end of the scale and is conducted by a trained professional for long-term rehabilitation. Crisis intervention refers to brief communication therapy as a preventative or acute response to a stress. The two types of therapeutic communications most appropriate for emergency responders are group therapy and individual therapy. Psychotherapy in the form of brief group therapy is very common for emergency responders when it comes to post-incident debriefing. Emergency responders have used this effective tool to talk or open up about an incident. According to the Handbook of Psychotherapy and Behavior Change, brief psychotherapy in a group setting has proven successful in workplaces as well as for critical incidents and PTSD. Alcoholics Anonymous we're going to mention, and AA is one of the best examples of organized group therapy. The program is primarily voluntary and uses a formalized social framework to allow victims to come to grips with their addiction. The social networking is very similar to a formal type of critical stress debriefing held by some emergency services after a significant event such as death of a child or coworker, a hazardous emergency scene, a mass casualty incident, or the death of a victim after a prolonged effort. How AA performs successful group therapy. First, they have meetings. These meetings are held locally for 6 to 50 people who meet regularly. Starting and ending times are predetermined. The team leader explains the ground rules and facilitates the meeting. First names are used exclusively, thus Alcoholics Anonymous. You have single share. Although the definition formally means that each person can only speak once, its basic intent is to keep one person from controlling the floor or its discussions. By limiting the number of times an individual can speak, it keeps everyone equal and encourages others to participate. Crosstalk or direct response to an individual should be discouraged because it can easily evolve into a discussion or an argument and deters others from commenting. The closing part of an AA meeting means that it ends on time and they close with some thoughts from the facilitator, reiteration of basic principles of AA, and an explanation that their feelings are normal. Additional resources are available. So AA is just one example of successful group therapy, and this gives you an idea of how it works. It's not saying you're going to go to AA for PTSD. It's just an example of how successful group therapy might work if you find yourself involved in some form of group therapy. Critical Incident Stress Management, CISM, is an organized form of crisis intervention used to manage the stresses of critical incidents. One of the most popular comprehensive stress management programs in emergency services, it consists of several core components. Since 2001, CISM has been scrutinized by some as a one-size-fits-all program that may not be as effective as once thought. However, there are several components that will likely be used in future behavioral health programs. Pre-incident CISM is training that may take the form of stress reduction, preparing for a PTE, or learning a healthy coping mechanisms. Incident response means that when an event does occur, CISM suggests that intervention crews should respond to the incident to gather information. If needed, they can provide assistance to members who need special attention. For large incidents, the first phase of a crisis intervention could be demobilization, an area just outside the incident where food and rest can be combined with information about critical incident stress. Post-incident CISM means that at some incidents, demobilization is simply not feasible. Some meetings will have the goal of defusing, where others will be primarily for debriefing. Let's talk about psychological first aid. Some researchers have questioned the ability of CISM to reduce the symptoms of PTSD and have suggested that psychological first aid, or PFA, may be more effective. The primary difference between CISM and PFA is that CISM uses debriefing or a discussion about the events that caused the distress, while PFA supports the needs of the victim without any peer counseling. There are two classifications of psychological trauma victims: primary, which are those who witness an event, and secondary, which are those who are involved later in the event, such as emergency responders. Many organizations, including the World Health Organization, or WHO, have discouraged the use of routine debriefing for primary victims of psychological trauma due to detrimental effects. Research has shown that debriefing of secondary trauma victims is much more effective. Let's discuss individual therapy. Individual therapy is another option, and unlike group therapy, is more private. Some of the more popular sources for emergency responders include mental health support, employee assistance programs, or EAPs, behavioral health assistance programs, or BHAPs, or chaplains. When it comes to mental health support, numerous professionals, including social workers, psychiatrists, and psychologists, deal with the specific mental health needs of individuals. These mental health counselors may be effective at treating the effects of PTSD, but can also treat an underlying illness that could manifest itself after a critical incident. Treatment usually consists of ongoing psychotherapy and may include medications or other rehabilitation. One of the advantages of utilizing a professional counselor is the fact that visits can be discreet. Sometimes these professionals could come from a referral or could be a component of an EAP through an employer. Let's discuss employee assistance programs. An employee assistance program, or EAP, is usually a component of a health benefit or a resource that is provided by an employer for employee problems such as substance abuse, smoking cessation, mental health issues. An employee with personal problems that affects his or her work performance can be referred to an EAP as a condition of returning to work, or the EAP can be contacted voluntarily. In many systems, the employer is not aware of who is using the program, and this is a must for an EAP to be accepted and utilized by the employees. The primary goal of an EAP is to fix problems before they spiral out of control. A secondary goal of an EAP is to be a component of progressive disciplinary process. Let me repeat that last sentence. A secondary goal of an EAP is to be a component of a progressive disciplinary process. Taking an EAP one step further, a Behavioral Health Assistance Program, or BHAP, utilizes key components of an EAP and adds resources from NFPA 1500, which is the standard on Fire Department Occupational Safety and Health Program, and the NFFF. Specifically recognized in the NFPA standard, BHAPs would provide the three immediate needs of an emergency responder, which are assessment, basic counseling, and stress crisis intervention. Referenced several times in NFPA Standard 1500, a BHAP can be designed around the needs of the organization, including the availability of assistance for family members. Let's talk about chaplains. Another way for emergency service organizations to provide emotional support for their members and families is through the adoption of a chaplaincy program. Chaplaincy programs exist in many hospital systems, correctional institutions, and the military. As opposed to EAPs, which are more clinical in nature, these programs or chaplaincy programs can provide unique guidance and assistance on a personal basis to those who need and desire it. It's important to choose a chaplain with specific qualities, specifically someone who is, of course, available, that's extremely important, approachable, and adaptable. It can be expected that working closely with mental health professionals will allow fire and emergency services to develop new programs and processes to ensure that emergency responders can continue to remain healthy. Some of the changes that we can expect to see are new, such as behavioral models, technological advances, and support systems. Let's talk about behavioral models. The National Fallen Firefighters Foundation, or NFFF, has recently released their plan for a consensus approach to firefighter behavioral health. Their research shows that past methods used for fire and emergency services were not always successful in providing the necessary psychological support. The new package was constructed using scientific data from other high-stress industries, utilizing the most up-to-date psychology, including after-action reviews, curbside manner, which is stress first aid for the street, trauma screening questionnaires, trauma-focused cognitive behavioral therapy, peer team training and coordination, and stress first aid. There are also technological advances. In addition to improving our physical safety, technology also shows promise when it better serves the emotional needs of emergency responders and their families. Many emergency responders learn better in groups and work better in groups, but some are more comfortable solving problems on their own. Therefore, it would follow that some would heal faster in a private setting at their own pace. Technology could provide solutions both for relative anonymity and for complete anonymity, as well as providing a support system at home. Relative anonymity means that everyone handles the stress from varied emergency calls differently. Some open up and want to talk about situations, and others want to keep to themselves. It could be that interpersonal relations are the most difficult for those who prefer not to talk about it. Although your partner may not have the courage to look you in the eye and discuss what is bothering her, the relative anonymity of texting or emailing allows her the ability to participate in a form of psychotherapy while remaining in her comfort zone. Society continues to accept informal communication. We would be remiss if we failed to see when it could be useful. Then there is the issue of complete anonymity. One other potential use of technology involved a study that used the internet as a platform for specially designed cognitive behavioral therapy, or CBT, for military personnel suffering from PTSD. According to the National Association of Cognitive Behavioral Therapists, or NACBT, CBT is a form of psychotherapy that uses scientific methods to help patients unlearn the way they react to specific stimulus. Unlike forms of psychoanalysis in which a patient lies on a couch and tells a psychiatrist about personal issues, CBT is less subjective, and internet-based CBT provides the added bonus of confidentiality. Although cheaper than traditional CBT, the study showed that internet-based CBT was just as effective. The study also suggested that mass counseling could be available for disaster situations while providing a level of privacy that allows users to feel secure. The advantages of a system providing mass group therapy and individualized care to hundreds of firefighters and EMTs on their own schedule in complete privacy cannot be underestimated. Then there are support systems that are available. Another advantage of an internet-based system is the possibility of adding family members. A web-based program that includes the needs of spouses, children, and parents would be beneficial in many ways to the safety and wellness of emergency responders. In conclusion, experience has shown that the psychological stress of emergency scenes can be as severe as the physical stresses. We can improve scene tactics for the next incident by discussing our successes and failures in an open format. CISM evolved into a successful form of group therapy, allowing emergency responders to discuss events and begin to heal. PFA and AARs provided the next step in responder well-being. Now, a comprehensive approach to behavioral health is emerging that could take Initiative 13 closer to its goals. We need to research, obtain, and implement the programs as they become available to us. And we need to continue to look to technology to improve the tools we have and invent new ones. Let's summarize what we talked about in this chapter. First, emotional and physical stress have many similarities, including the causes, short and long-term effects, and treatment options. Different people handle different situations differently. They also arrive at emergency scenes with varying levels of personal stress, such as family, friends, work, or finances. We also talked about how many emergency responders do not make it through school before deciding to quit. Some may abruptly quit due to the stress of responding to emergencies. Others continue to perform their duties but have scars from past incidents. We also talked about how potentially traumatic events can lead to burnout. In an effort to cope with stress, some choose unhealthy coping mechanisms such as alcohol or drug abuse. Or overeating. There are people that overeat in an unhealthy fashion in a bid to cope with stress. So that's another thing that isn't mentioned here, but is certainly a problem, and that can lead to heart disease, injury, all kinds of things. Alcohol, we talked about how alcohol can evolve into alcohol abuse, or alcohol use can evolve into alcohol abuse. Alcohol is sometimes used to raise spirits, but technically is classified as a depressant. It is a central nervous system depressant. Some symptoms of alcoholism include a desire to drink beyond control, a need to continue drinking once started, and then drinking when there is every reason to not drink or remain sober. We also discussed how emergency responders may resort to drug abuse because drugs are quicker, more effective, and less obvious than alcohol. Sometimes it's due to working in an environment of close proximity to prescription medications. Also, suicide is a significant problem affecting emergency responders, but many times it is not tracked. There have been several suicides by emergency responders after high visibility rescues. A potentially traumatic event may lead to acute stress disorder. While untreated, it may proceed to post-traumatic stress disorder or PTSD. PTSD can have symptoms ranging from flashbacks or bad dreams, avoidance symptoms, or hyperarousal symptoms. We also discussed how different things can trigger a response for someone suffering from PTSD. And one example are roadside memorials. And they are an example of something that can trigger a response to a traumatic event, and it could be completely unrelated to that roadside memorial, but just seeing it can trigger a memory in someone suffering from PTSD and cause them to, in essence, have a meltdown. We also discussed how some forms of treatment include psychotherapy and crisis intervention. Psychotherapy can occur in group therapy or individual therapy. An after-action review could be considered a form of early group therapy and should concentrate on the mission of the responders during the event, what went well and what could have gone better, and what might be done differently and who needs to know. We also discussed how AA or Alcoholics Anonymous is an example of group therapy that follows several guidelines that include their meeting structure, single share, crosstalk, and closing. The same guidelines can be used in crisis intervention. And again, let me reemphasize that if you're suffering from PTSD or you find yourself needing critical incident stress debriefing or therapy for something particularly traumatic that you went through, you won't find yourself in an AA meeting. We only used AA as an example of how good structured group therapy will generally operate. We also talked about how CISM, or Critical Incident Stress Management, is one of the most popular comprehensive programs used by emergency services over time. It has pre-incident, incident, and post-incident components. Defusing and debriefing are both utilized in the system. And finally, we talked about how psychological first aid concentrates on supporting the needs of the victim without peer counseling and differs from CISM by eliminating the debriefing process. We talked about how individual therapy can consist of mental health support, employee assistance programs, behavioral health assistance programs, and chaplaincies. A BHAP utilizes key components of an EAP and includes resources from NFPA 1500, including assessment, basic counseling, and stress crisis intervention. Chaplains are most successful when they are available, approachable, and adaptable. Future research and programs can benefit the psychological support of emergency responders through improved behavioral models, technological advances, and support systems. And finally, we talked about how the NFFF has released a behavioral model that includes after-action reviews, stress first aid for the street, trauma screening questionnaires, trauma-focused cognitive behavioral therapy, peer team training and coordination, and stress first aid. And finally, technology would likely improve counseling by utilizing relative anonymity as well as complete anonymity. Class, thank you for your time spent using this tool. Remember, it should be a good supplement to your textbook, and remember that this lecture is not a substitute for you reading the text, and make sure that your text remains your primary source of information. If after studying your text and listening to this lecture you are still unsure about a portion or any of the material or any points of the material, make sure to contact your instructor. Thank you again for your time, and we'll meet again in Chapter 14.